All right, well, since everyone did get quiet, I'm Mark McClellan, Director of the Duke Margolis Institute of Health Policy, and privileged being one of the co-chairs for the Executive Forum here at the Healthcare Payment Learning and Action Network, and I'd like to welcome you to this afternoon's session. Yes, you read the title right, Moonshots and Bellyflops. So in this session, we're going to do things maybe a little bit differently from the typical update on different elements of value-based care, whole person care, and the journey to get there. The focus here is on major initiatives or important initiatives to try to advance the goals of the LAN, accountable care, value-based care, whole person care, that did not work out quite as intended. They did not achieve their intended goals, and how the organizations involved incorporated or leveraged or otherwise took account of the learnings for their future work, and maybe even shared some of those experiences. Look, this, as you know, is a tough journey in the Healthcare Payment Learning and Action Network. It's now been a decade of work that the LAN has been involved in with many of you. I just saw Bill Golden dating back from those early days. And while I know this has been a challenging journey, we've had some good discussions about that so far today, it's also clear that our healthcare system is in a different place than it was 10 years ago. We still got the announcement of the latest results of the LAN Payment Reform Survey for the United States ahead this afternoon, but you don't have to wait for that to see that there are new kinds of collaborations happening, important recognition that advancing whole person care is about more than changing the payment systems to enable it, but recognizing the context in which reform is occurring, the need for a reform and at least a path towards, some cases, transformational changes in healthcare organizations and how they work together, what they're supporting, data, infrastructure, staffing, and other features are. So it's been a journey, and on any journey like this, there are going to be missteps, setbacks, maybe even dropping off into the occasional ravine, but this effort has continued to move forward, and we wanted, now that we're a decade in, to maybe raise up the importance of learning from the things that didn't go right, and hopefully facilitating more opportunities to share those learnings to help us move forward more effectively together. So this session will have some discussion of how these kinds of belly flops can contribute to innovation, how they can be built into evaluation. Notice, I should remind you all that there's a session coming up on more rapid learning as our data gets better and our techniques get better. I think you should view this as a complement to that one, kind of looking at it at the big picture from failures. So I want to bring up three failed speakers? No, just three speakers who are particularly brave because they are, you know all the people up here, many of you do. These are very serious reformers, but don't take themselves so seriously that they can't talk about the stuff that went wrong along the way, and also have the courage, let's say, to step up and talk about what didn't work for the benefit of all of us, to learn from that experience and not do it again. So very pleased to be joined again with Dr. Judy Zergenthal from the state of Washington. You know her, had a chance to hear from her this morning. Dr. Nick Shore and Dr. Purva Rawal from the Innovation Center. See the bios on the slide and in the material. So I just want to get right to the material here, since there is so much good material. So I'm going to ask each of them to start by telling us about an initiative that they've been part of, a major one with a lot of dollars, a lot of effort, a lot of time at stake, that did not meet its intended goals, that were either a reform effort or a moonshot that kind of ended up more like a belly flop, and what that led to in terms of insights and a better path forward for next steps. So Purva, do you mind if I start with you?
Yeah, I'm happy to start. I'll just start by saying that I'm really excited to be on this panel, and it's not because I'm brave or courageous. I was voluntold by Kate Davidson that I got the Bellyflops panel, but honestly, I'm really excited to be having this discussion because I think it's a real testament to how far we've come in the movement to value, that we can have entire sessions to talk about what hasn't gone well, the places where we've had belly flops and failures, because if we don't have those, we can't have successes. And clearly, we've all had a lot over the last decade, and hopefully there's a lot more to come. But belly flops are a really natural part of the innovation process. I see a lot of my colleagues, Sarah Fogler and others here from the Innovation Center, and they know that a lot of the things that we test and try don't work. If you've tested over 50 models, not all of them are working and not going to work, but that's a good thing because that tells us where we're going to go next. Innovation is iterative. And I think we probably learn and grow more from the things that don't work than oftentimes from the things that do work. And I know we're also going to talk about Moonshots later too. At last year's LAN Summit, I actually had the privilege, and it was a panel that was moderated by Jeff Miklos. I know we all truly miss him here today in particular, but a year ago, Jeff moderated a panel that I was on about care delivery transformation and the way that value-based care has driven changes in our delivery system and the successes. And so it's kind of fitting a year later to be sitting here and thinking about, well, what didn't go well and what did we learn and what did we learn from it? And so there are a lot of different maybe scenarios for me to talk about, but there was one model in particular that the team and I felt like illustrates well. Sometimes we do have belly flops, and then what do we take from them and what do we learn? So I decided to focus on the ET3 model, which some of you might be familiar with, and for those of you that are not and don't know all of our acronyms, it's the emergency triage, transport, and treatment model that ended 2 years early, actually. And for those of you that may not know, the goal of the ET3 model was to reduce unnecessary trips to the hospital emergency room by offering patients the opportunity to either receive treatment in place or treatment to an alternative destination like an urgent care or a federally qualified health center, FQHC, or other setting when it was clinically appropriate. The idea being this could reduce costs to the system, reduce costs to individuals, help with hospital or ED overcrowding, et cetera. But we, like as I said, ended the model 2 years early because we really didn't have the participation that we thought we would. Much lower than expected participation numbers and pretty high operational costs as a result for the center. So when we often design models, why didn't it work? Well, when we design models, we start with a theory of change. And so for those of you that are researchers in the rooms, you'll appreciate that. But we really think about what are the problems we're trying to solve for, what are the mechanisms for addressing those problems, and then you design a model around that theory of change, and you test that theory of change, did it actually work? And on paper, like as I said, it made sense that this kind of a triage model might be effective for patients who don't necessarily need to or want to go to the emergency department. But what we found was that, again, we didn't have the participation, and as we dug into why, like where did our theory of change not match the real world outcome that we were seeing, it turns out in the moment during an emergency, it's a huge shift for both the patient and the EMS provider to say, here's someone that called 911, and now we're going to try to either treat in place or treat an alternative destination. We found that there were factors as we dug in that were both in our control and not in our control that probably contributed to the outcome that we saw. And in terms of the things that we could control, we didn't actually anticipate, and I don't think we had as clear an understanding as maybe we could have about what does happen at the point of care and the decisions that people are making and the decisions that providers have to make in the moment, especially when we're talking about Medicare and Medicare beneficiaries, many of whom are obviously aging and have multiple chronic conditions, and their decision-making process may feel and look different than a younger patient, for instance. And then there were a number of operational factors that were not under our control as well. So the model implementation took off during COVID, and so that obviously had some impacts. Workforce shortages that are affecting all sectors of healthcare played a role in the model as well in terms of hospital ED staffing shortages, EMS shortages, and then the alternative treatment destinations themselves also oftentimes being understaffed. And so those, I think, are many of the factors when you put them all together. There wasn't a single thing that led the model to have lower than expected participation, but a number of things that were under our control and not. The things that were under our control, I think, this is an example of a model where we've taken those lessons learned and put a number of changes into place in terms of how we are testing our theory of change on the front end, how we're understanding what's happening in our models as they are running to be able to course correct and to make changes and decisions quickly.
In terms of those ways and the things that determine that, could you say a little bit more about kind of the lessons that came out?
I think a huge one is engagement up front. So when you're thinking about, you said in the context that the care is happening in, we did this in our guide model, and I see some of the folks leading our guide model here too. We did a lot of upfront work in terms of listening sessions, meeting with providers, patients, family members to understand what are the actual pain points in the system for them, and then being able to design a model around to address those pain points that we're hearing directly from the end users of our health system, right, the providers and people. I think meeting participants where they are too in this case, Mark, was really important. And so in many of our state-based models, there needs to be a framework, but also some flexibility because these are locally, those care pathways, the context that care is occurring in look really different. And so people need to be able to form different kinds of partnerships and leverage different local capabilities to succeed. And then stakeholder alignment, we can talk more about that later as well, but multi-payer alignment in particular. And how do you align directionally early in order to get that kind of alignment across different payers is really important too.
Engagement, alignment, some important lessons there. So go from federal belly flop to the states where belly flops also occur. Judy, maybe I know you've got a good example to talk about.
Yes. Hi, I'm Judy, and I have failed, and I have learned from it. And I wish that for all of you as well, because I think if there are not failures, we're not pushing the envelope far enough, we're not trying things. To really improve care, we need to take risks, and sometimes those risks don't work out. So I'm here to talk about APM4, which is Alternative Payment Measurement 4, which follows 3. So you can see the succession that's going here. Presumably there will be a 5, but we're still working on our learnings. But this was a voluntary value-based payment model for federally qualified health centers. 16 of our 31 FQs joined the model, and it ran from 2017 to 2022. Prior to the pilot, FQs were reimbursed in their cost-based model with encounter rates, and during the pilot, they were instead reimbursed a prospective per member per month, and they could never be paid less than what their encounter rate was. And the goal was really to move away from the in-person, churn the visit kind of seeing folks and find other ways to improve health outcomes, improve quality, go find the people that are sick, help them get to care, figure out what they need, that sort of thing. And the short end is that the state spent $280 million more than we would have spent otherwise. And we did not see any significant increases in quality, no changes in cost, no changes in utilization of primary care visits, emergency department visits, total claims number, they were all sort of the same. So a piece of this overspending was because of COVID, because COVID hit in the middle of that, and COVID did what we sort of wanted to happen. People stopped getting in-person care and instead, got virtual care. But also during COVID, our enrollment in Medicaid really swelled, and most of those folks got attributed to FQHCs, and then their PMPM went up. And we learned some things from this. I think one of the things, we did an evaluation, one of the things that was pretty interesting that we hadn't really realized earlier, but because it was a voluntary model, the FQs that were already good, that were already low cost, that were already high quality, those were the folks that joined the model. They had an $8 per member per month average, lower total cost of care than other FQs. And so I think many times in VBP models, you get people who are already like drinking the Kool-Aid and want to do it. And so I think, how do we spread that to other folks? From the FQ perspective, they actually thought this model worked very well. Not just because they made a lot of money, but also because they felt like it helped them shift their framework to thinking about non-visit-based reimbursement, to thinking about community health workers, and that this was an investment in some of that infrastructure care that in the future was going to help them do other things. I don't know, maybe I'll stop there.
Okay, and thank you for sharing. It's a great story. And I do want to come back to some of the challenges and issues that are particular to federally qualified health centers, safety net providers. I think there are even more lessons coming out of your experience and your commitment in that area. But first, let's go to bring Nick into this discussion. So Nick, you're at University of California, Berkeley now. Prior to that, Common Spirit, KP, so a lot of opportunities for Bellyflops.
And a lot of them occurred, yes. It's been a series of them. And it's great to be here with all you guys. I'll actually talk a little bit more about a process one. Before Common Spirit, I was with the New York City public hospital system. Early in my career, a primary care doctor at Bellevue, interested in pop health. Someone in the city's public hospital and clinic system had applied in that first wave of MSSP, and nobody really knew what it was, and you're looking for something to do here, figure this out, what this is, and build this thing. And so embarked upon a long series of many mistakes, having no training to go in and try to figure that stuff out, but an incredible opportunity. But in MSSP, a safety net system like that, long odds, baseline, very low benchmark, didn't really have resources to invest up front. But what I learned in sort of starting to pull this together was there's extraordinary assets in a safety net system like that in the people and the mission, and that's why people get up in the morning, is to try to do pop health before they necessarily called it that. And so, it was a really, really great experience to try to channel that into something that was that could be successful. And year one closes, performance comes back, and to our great surprise, we earned shared savings. Excited, surprised. Like, oh, I guess we get to give away all this money. Everyone's going to love us. It's going to be, give us all this runway to build on what we're doing. But this is the public hospital system. Zero precedent for any sort of incentive, payment, distribution, even just functioning as a network as a whole was very new for a lot of the stakeholders. So I go about, talking to the doctors and the physician groups, and half the doctors were unionized, and there were just all these stakeholders, and the more the conversations happened, and it more became like, oh, there's this money, it became less about what was trying to be achieved in the first place, and it was just a mess, and culminated by getting a call from City Hall asking, are you going to pay out money to the doctors? And I said, yeah, they're like, no, you're not. We're in negotiations with the firefighters union right now. Incentive pay is a thorny issue there. We can't be seen doing it over here. And you're just like, this is so different. This is how the program is built. And you try to explain it, but everything was just so new to all these stakeholders about trying to do a population-based payment in this way. So it looks like we're not going to be able to do it. We're going to have to withdraw from the program. A year and a half goes by, we finally get everyone sort of signed off and on the board, and finally get to share the shared savings payments and spend a lot of time on where they go. By that point, we had earned a second year of shared savings payments, so they all went out together way after the fact for an incentive. But I'm incredibly proud of that team and that work. They just earned shared savings for the 11th straight year. The only ACO in New York State to do that and out of a safety net system like that. But each year we paid out, it got easier. We learned a little bit more. We learned, how to bring the stakeholders along. And it became a chassis that we added other types of value-based agreement and incentives onto. And, I think ultimately, like what can feel like a belly flop, sometimes this means, you're on the curve of doing something really hard and really important. And so I think that's true in what all of us are trying to do here. We do our goals a disservice when we pretend that these things can happen really quickly and these models are going to work right away. And it's hard work. We're really fundamentally trying to change things, and the iteration and patience that takes can lead a lot of things to kind of go astray earlier on. But,
So, thanks for the story and for the lessons. Maybe just push a little bit. Purva talked about early engagement being important from the patient standpoint, from the providers involved in care. Yours also is sort of the purchaser and other contexts as well. Has that evolved now? Does City Hall get the concept of shared savings?
They get it now, yes. Once everybody realized it was something, what it was, something to be genuinely proud of and something they could brag about, it became an asset that we could build. But that's it's hard enough to explain to people in healthcare what this new program is. So it's definitely took years of sort of cringy misstatements by other parts of city government, but again, a little bit better every year.
And I have to say, a big part of this decade journey has been around describing what this effort is all about for normal human beings, and we're still on that journey too, whether it's patient-first care or longitudinal coordinated care or access and affordability with innovative care. It's still a process.
100%. It's huge. We lose so much heat loss in nomenclature and just sort of education on this stuff. And it keeps changing because it needs to.
And a great area to keep learning together. So just to follow up on a bit of this, Judy, maybe come back to some of the population providers that you were involved with the FQHCs. Nick talked about an example from a famous safety net hospital health system. How are the lessons that you learned fitting into your next steps on advancing accountable care in the safety net? This is a challenging space. There have been special CMS efforts here. It's not just a matter of CMS, though. Medicaid's a really important payer in this population, which you have lots of experience with. I was just in Texas a week and a half ago with some of the safety net providers there who have pretty high rates of uninsured payments, some state-directed payments that help, but trying to get to longitudinal care for people who may not even be in insurance, or at least may not consistently be in the same insurance. And and then the HRSA payments, the directed payments from programs, that's a lot to try to align into longitudinal care.
Yes. I think that having those relationships and having that conversation is really important. Purva talked about this too. One of the things that the FQs really found hard in this model is that the model kicked off and then almost everyone at the healthcare authority changed. The director changed. I came in, some of the staff that were directly in charge of this program left, and so they really felt like they weren't sure, did the new folks appreciate this model? What did they feel like? And so having those conversations is helpful. I think we also learned about measurement and the consistency of that. So we didn't have a lot of along the way sort of guideposts about how much were we spending and were quality measures changing. I'll say personally for me, some of the quality measures we used, yes, they're HEDIS measures, yes, they're ones we used all the time, but they're not really adequate to get at how do you measure changes in this population's health. And in particular, how do you measure changes in chronic conditions over time, which really takes a lot of work and time, as Nick said. I think payment is a lever, we started out with this on the first panel, that payment's a lever, but it's not the ultimate outcome. And so thinking about how do we really use payment to incentivize some of that. And I think one of the things we learned in 2026, our managed care organizations are going to start to be financially incentivized for decreasing disparities in quality measures. And I think one thing we didn't do in this model, but I think would have been helpful, is looking at equity, looking at how there are differences in populations, and getting a little more granular. Are there specific populations that did really benefit from this? And I think that is for sure some of the work to do.
So more attention and explicit focus on guideposts along the way. So measures like measures that focus on changes that may help identify problems earlier to enable course corrections. Purve, you talked about the ET3 effort, but there's a broader effort underway at CMMI now on this concept of more rapid learning. So not just, let's start a 5-year payment reform pilot and check in down the road. I know that's an oversimplification, but it seems like a more focused effort to have some of these shorter term opportunities to check, maybe more predictably adjust model features, maybe help organizations learn how to succeed better. It seems like this fits into a more general theme at CMMI and elsewhere, that if you're gonna fail fast, or at least identify the opportunities for correction earlier. Could you talk a little bit about how CMMI thinking more broadly is evolving around, or I guess, early indicators of failures, or early indicators or opportunities for improvement?
Yeah, I'm happy to. One thing I'll say is, I talked earlier about having a theory of change for a model. And even in upfront engagement allows you maybe to have a stronger theory of change so that you're a little closer to what might actually happen on the ground. But it is not just upfront engagement, but continual engagement. So as we have a model that's operating, it's really important that we are hearing from our model participants, others in the ecosystem, and in particular patients. One of the things that we've done coming out of all of the lessons learned from the models that have worked and that haven't is that beneficiary engagement across the life cycle of our models is really critical. Because that allows us to be able to see, are we seeing the kinds of quality, experience, and outcomes changes that we had theorized, and is that actually coming to fruition over the course of a model? And if it's not, or the payment changes aren't having their effect, or model participants feel that model's not financially viable, that we are picking up on those things quickly and early, and then I think somebody else used the term course correct, so that we are able to course correct. And one example of a model where we made a number of financial course corrections across different leadership teams was our bundle payment for care improvement advance, our BIPC advanced model, where that model was experiencing some pretty significant losses in an early cohort. And so we went, the team at that time went back and put into place a new pricing methodology and made a number of changes that would help stem some of those losses. We're going to keep the model going. We knew there was some really important care transformation work that was happening as a result of that model, especially in that discharge period for patients. And there was maybe too much of a course correction because we saw a significant attrition in that model. And so a few years ago, we went back to the drawing board, really heard from our model participants about what was working, what wasn't, and made some adjustments to that pricing methodology to be able to keep as many participants in as possible. And we knew it was a really critical part of the broader work and the broader portfolio around episode management and specialty care. So that's an example where you can calibrate and course correct and make adjustments during a model's life cycle to be able to balance both savings, continually driving care delivery change that's successful, and supporting our model participants. But I think the other thing you were also alluding to Mark, is some of our newer work around rapid cycle identification and testing of what's working. And a lot of this came out of the work that we did over the last few years, and something we've been calling our transformation initiative. And I talked earlier about the care delivery paper that we had come out about a year ago. And coming out of that, we know that there's a lot of care transformation happening through value-based care. We don't always know what's working. And so in order for us to identify what's working and then to be able to accelerate adoption of what's working is really important. And so we are building new capabilities and launching new capabilities to do that through our models. And I think it's such an exciting thing, probably one of the things I'm the most proud of being a part of the last few years, because I think it's a real contribution that the Innovation Center can make to really building a learning health system.
Yeah, and I think we are going to hear more about that at another session today too. And it's interesting to put together sort of the big picture that we've talked about here, overall what's going on in the model, making sure you're tracking that, your logic model or theory of change, with more detailed ways of seeing how we're doing quantitatively along the way. It's like getting more systematic about that. But Nick, I wanted you talk about your public sector experience. You also spent some time in the private sector, and public belly flops in the private sector, kind of those can be problematic, right? I mean, I've seen a lot of case reports of steps to implement different versions of accountable value-based care. They tend to have positive stories associated with them, not negative. Is this, and I get that there's, people are watching, and some of these companies are publicly funded or public companies with private funding, but have to have face some real sensitivities around transparency. This is a hard question, but are there ways to help bring these private sector experiences more into this overall evolving ability to identify the bigger challenges, share the learnings from them, and then build out systems to avoid those problems in the future and learn more quickly when they're happening?
Yeah, that's actually exactly one of the main reasons I went to Common Spirit after being with the public system in New York. Was it felt like these huge segments of the healthcare system that coming out of academic medicine or elsewhere are kind of blind spots. Like you don't really know nearly as much, and as much is written and published about them. And so it was fascinating to get to see some of those other spaces. But especially coming from academic kinds of setting where there's journal club and there's sort of a pride in challenging everything, and very different. There is much more of the sort of financial incentive toward market share and growth and competitive positioning, which is not conducive to being open about your flaws and weaknesses. And it's built on this sort of infrastructure that has a lot of inertia to it. That is, it's based on widgets and fee for service, and finding that volume, and that definitely does explain, I think, some of that. What we see is not seeing as much about what's going on there. I do think value-based care represents, and in my experience, has been an opportunity to get a foot in the door on some of that and change some of those norms. Because when you're in a population-based payment model, you're invariably taking on accountability for quality and costs with a group of internal and external stakeholders across the care continuum, right? And that's a very different concept of performance. And spent a lot of time inside health systems trying to kind of help kind of adjust our financial thinking as an organization around that sort of shared success model, because it's against a lot of the instincts, a lot of the inertia. But I think it does create this, certainly at least within those networks that you're creating in your community, there's sort of a bigger space to be able to think pragmatically and share lessons learned. And I think that starts to, and you're also you're competing to be an attractive partner in the community to get people to want to work with you. And so there's definitely some openings there that I think have been helpful, and I've certainly tried to push on as much as possible. Because like this stuff is too hard to pretend you know what you're doing all the time, and so. But I think that model, shifting to that model, is an opportunity, and you do see more openness, I think, than in the pure productivity markets.
I know the LAN is trying to create more of that culture, including through this session here right now, as our partnerships get stronger, the supporting data get better. it really helps, really a lot of potential to speed this process. So we've talked a lot about the belly flops. Before we wrap up, I want to talk about moonshots from here on out. I'm going to ask each of you about a moonshot that you see an opportunity for going forward. Would say at the highest level, remember in the Healthcare Payment Learning Action Network itself, from the beginning, there have been kind of moonshot goals around payment reform. We've talked about, we've learned about through failures and all this experience. It's not just the payments, but that still is an important set of goals. So 100% of people in Medicare, much more rapid progress than we've seen. If you look back at past trajectory and other payer programs, that's still kind of a moonshot here at the LAN overall, and would point out that that goes back to the previous administration as well. The Trump administration moonshot here was 100% by something like 2024, 2025. So still moonshots around. What's top of your moonshot list? I'll start with Nick.
Yeah, it's a really fun question to think about, and you know, I would love to see more, if we can figure out how to bake in big public health goals, specific public health goals, into some of these programs. You know, they're all oriented around, you know, meeting comprehensive population needs, but I think in particular about hepatitis C, which is this extraordinary public health opportunity in front of all of us. Most common chronic viral illness in the world, causes all kinds of suffering and high cost in our system. And, you know, as of a decade ago, it's curable. It's really totally changed. It's entirely within our ability to eradicate it from the planet. And that's crazy. And as opposed to being sort of vaccine driven or things that can be more community health worker focused in how you scale it, it really goes through the healthcare delivery system. The direct acting antivirals have changed the game. They cure virtually everybody. They're very well tolerated. It's a whole different ballgame than how we were all trained to treat hepatitis C before then. But if you're going to actually eliminate something like that, no health system can do it alone, and no stakeholder can do it on themselves. It's fundamentally a geographic endeavor to try to eliminate and achievable geographic effort. But I think figuring out how to identify a shared goal like that all the stakeholders are bearing the burden of, and the communities we serve bearing the burden of together, and patients moving around. What can we do together that we can't do on our own? And what is really achievable from a public health perspective? When I reached out to other competitor health systems, population health leaders, about doing something around this, so much enthusiasm. You talk to clinicians, they would love to do something. It's so satisfying to actually cure a chronic disease. How often do we get to do that? And so you could see people light up. And I think just a little, if we can figure out in some of these models how to have a little bit more wind at the back from a policy and payment perspective to drive that, I think, you know, we can do great things along the way.
And so in this one, it's partly the drugs, they're curative, and the drug pricing, where there have been some progress and some, coming to you next, some innovative ideas on how to address that. But it's also the delivery system, finding the patients who have Hep C today. A lot of them don't have easy, routine access to care. They got other things going on, complicating their lives. And then I think for many of the primary care practices that want to help, they also would like to have some specialty care hepatology backup when needed, and that's not always easy either. But yet, over the past decade, we have made a lot of progress on all those fronts together. And I got to say, something like that I find more compelling than 100% of payments in category 3B or 4. So, thank you for bringing that back. Thank you for bringing us back to what really is the focus here. Judy?
Yes, so Washington State has a moonshot on hepatitis C that we're making progress on, but
that one's taken some time.
It's taken some time, yes. Gentle pressure applied relentlessly. That is what has to happen. But I'm going to talk about something different. Another thing near and dear to me is primary care. And primary care in Washington State, primary care everywhere, it's just not working for people. Our current healthcare system is not working for people, and it's not working for clinicians with record numbers of burnout. And so in Washington State, we've had for a few years now a multi-payer effort on both the Medicaid and the commercial side. We're now a making care primary state, so we've brought Medicare to the table. And I am really hopeful we'll get to better behavioral health outcomes, we'll get to better prevention, acute care, chronic disease management. We'll make a real place to improve population health and to allow people to be their best. So that's what we're doing.
Great, and also not just the category 3B4 models,
Yes.
important as those are, and it's nice to see for both of you. Certainly the Moonshots aren't getting less ambitious, and I'm taking that as a sign that we really do feel like they're, with what we're learning along the way and these further steps we can build on, there is a, if anything, a somewhat easier, not easy, but easier pathway to get there.
I will say part of the payment mechanism is getting to category 4 for primary care. So it's tied, but you're right. The important thing is people and
this
making
helps
them better.
motivate
Yes.
all these pieces together. Purva?
Yes.
I don't know that my moonshot is going to be that surprising, but maybe it's because we're all used to talking about it. But I'm going to double down on our accountable care goals as a moonshot. 2021, when we, almost 3 years ago, we put those goals out there, accountable care was not part of the lexicon in the way that we were thinking. And today's theme is so much about payment being an enabler of care that centers on people. And I think a lot of that was because it was a big moonshot in 2021 to say, we're going to get all of our beneficiaries in accountable care relationships that recenter us around what people need and what the providers need that are caring for people. And I think about how far we've come since 2021. We are defining it as an industry. We are measuring it, starting, and today, Ellen is going to be talking about the,
some more detail.
Yeah, with a lot more detail, and we're measuring it across not just Medicare fee-for-service, but MA and commercial and Medicaid, and that's just a huge advance. And for Medicare fee-for-service, we have over half of our beneficiaries in those relationships, and we are, continually pushing on other pathways and opportunities to get more folks that kind of longitudinal, person-centered care. So we haven't gotten to the moon yet on that one, but I really believe, especially because of the work that the LAN is doing, that we'll get there.
Are our moonshots getting clearer in the sense that it's payment, but payment is an enabler, so something you have to measure, and by this focus on payment as a moonshot goal, that helps get more attention to tracking how we're doing and figuring out why the payment reforms aren't moving faster. But I do want to, it's, no offense, but Nick's sounds more compelling than yours in terms of like this is really, so are we getting better at putting those together? So you think about the LAN, you think of overall for our alignment efforts, that takes some motivation, and we're seeing alignment happening not just on the payment features, but measures and benchmarks. Speaking of something that, ET3 and or especially the BPCIA issues, data sharing. It seems like it's getting a lot more clear and connecting to the kind of thing Nick was talking about.
Yeah, I think, another thought that I was having around Moonshots, and you used the word measurement, and so my mind was also going to quality measurement. And the fact that, as we're putting all these payment pieces together, the next place we've really been pushing forward on is our quality pathway at the Innovation Center, and really thinking about quality measurement and, how we reduce burden. How do we get to not just meaningful measurement for providers and patients, but really thinking about measurement as also quality as an enabler. And a tool for communication between patients and providers and the kind of care that we want to have. So I think if the moonshot doesn't seem maybe quite as ambitious, maybe that's a good thing, because it means we are maybe simplifying things and have a clearer set of a clearer vision and a shared vision that we're all trying to get to.
Out, thanks to all this work. Nick, you were gonna.
Yeah, MSSP is the core of any subsequent moonshot in this space. It's really the tip of the spear. It's what has allowed a lot of the fundamentals to change, a lot of the education to happen over years, right? And if that were to change, or if that were to not keep charging forward in that way, so much less is possible. So that is even in a system with 2.5 million value-based agreements or value-based attributed patients in some form. We always came back to MSSP because people it was understandable, it was relatable across states, it was transparent, we could always do so much more. It was always the population we started with, the data we started with, and it would have been so much harder. So yeah, I think continuing to triple down on that is essential.
So like the experience you started out with, it sounds like you all at Bellevue got an MSSP basically, this sounds like something we should try. And what do you know? We beat our benchmark. So it's come a long way since then in terms of fleshing out all of these pieces. And I just want to thank all three of you for coming clean, for being frank about all of this, but also in all seriousness, ending up at, think about the moonshots that we're talking about up on stage today and that many of you in the room are engaged with. These are moonshots that really matter to people, whether it's accessible primary care that helps me with my problems that I can afford and get it conveniently, maybe even at home with my phone, or eliminating Hep C, something that states are trying, or some even national efforts to try to advance. It's nice to see the progress, and it took a lot of belly flops along the way, but it's really great to see how much all this has been fleshed out as we look ahead to the Moonshots for 2025. Thank you all very much for joining me today.
Thank you.